First of all, I congratulate IRSI for encouraging such an activity by their young cubs and the cubs for running it so smoothly, so professionally. So, topic given to me was ocular oncology, when to refer. This is my favorite slide. This looks like a busy clinic. When you become a busy refractive or a cataract surgeon, you'll have your clinic full of similar looking patients. Everybody seems to have a cataract, everybody seems to have pterygium, everybody seems to have pincula, etc. But what is good, what is bad, and what is ugly? Although you might have seen this movie several times, suddenly, when all these stand together, it's difficult to say who is the good one, who is the bad one, and who is the ugly one. Similarly, tumors. Unless you look at the tumor very critically and look for a particular feature in each tumor, it's sometimes very difficult to say which is benign and which is malignant. For example, this is a papilloma and you want to remove it, of course, but histopathology would be mandatory because in a papilloma can be hidden squamous cell carcinoma. And when a papilloma changes its color, becomes, say, broad-based, papilloma is supposed to be pedunculated, it becomes sessile, base is indurated, it is hemorrhagic, then you suspect that it is turned into a malignant tumor. This patient has several papillomas, but one of which has changed its color. So that is an indication that it is turned into malignancy. And if you're capable of surgical excision with clear margins and cryotherapy, of course you should go ahead with, because this is not going to cause functional problems. But if you want to refer, this would be one such case. So any change in color, vascularity, size of a lesion, new onset induration, base fixity are the ominous factors for a papilloma. Or if a patient is elderly and has multiple sudden crop of papillomas, then possibly you should consider immunocompromised status. A dry looking nodulo-ulcerated lesion with or without pigmentation is a basal cell carcinoma. And here you need a protocol-based management where the tumor has to be excised with 4 millimeter clinically clear margins with intraoperative frozen section margin control. So as this squamous cell carcinoma, excision would be as large as this. So you need a good reconstruction, and that would be a case for reference as well. So all suspected malignant tumors need referral, and these generally present as nodular, nodulo-ulcerative or ulcerative lesions with vascularity and loss of eyelashes. Now, if you have two ladies like this, elderly ladies with bumps in the eyelid which look like chalazion, now which one is a chalazion and which one is not? That's often a question. And unless you evert the lid, you cannot comment which one is a chalazion. Short of that, without everting the lid, if a lesion were to confine itself to the tarsus in a young individual without thickening of the lid margin or loss of lashes, that generally is a chalazion. But if it is higher than the level of the tarsus with thickening of the lid margin and loss of lashes, that is generally not a chalazion. Both these ladies have lesions which is higher than the level of the tarsus. And when you evert the lid, the diagnosis is obvious. Both are sebaceous gland carcinomas. So any nodular lesion in an atypical age group, elderly individual with thickening of the lid margin, as you see here, and I would show that in a high magnification. Suppose this posterior lesion was not present at all. It was still slightly early. You can still diagnose sebaceous gland carcinoma by looking at the thickness of the lid margin. This is normal thickness lid margin. This is almost twice as thick. Sharpness of the posterior lid margin. It is sharp here. In the area that is involved, it is rounded. And you can look at the meibomian gland orifices. They're all lost in the area that is involved. And a loss of lashes. Putting it all together, even if the patient looks like as if he or she has chalazion, this may be sebaceous gland carcinoma. And even if you want to excise it or do a curettage, go ahead, but send the material for histopathology, confirmation of which would mean that you have to refer it for an oculoplasty opinion and a lid excision of the complete excision of the tumor. So that is mandatory. Nodular tarsal-based lesion with thickened, rounded eyelid margin, loss of lashes, and loss of meibomian gland orifices is sebaceous gland carcinoma. This is clearly not sebaceous gland carcinoma. You can see nice round pouting meibomian gland orifices. This is definitely sebaceous gland carcinoma. Now coming to a variant of sebaceous gland carcinoma, which arises from the glands of Zeiss, which is present close to the eyelashes. That happens in the eyelid margin without a tarsal-based lesion as such. So you should be aware that glands of Zeiss can also cause sebaceous gland carcinoma. Now coming to individuals with unilateral blepharoconjunctivitis. This patient has unilateral red eye. And when you look at the eye carefully, you find that there is breach of the limbal barrier. There's some amount of pannus or conjunctivalization of the cornea, which may look like limbal cell deficiency or stem cell deficiency or even squamous cell carcinoma to you. But when you evert the lid, it's very clear that this patient also has sebaceous gland carcinoma because he has the same features: widening of the lid margin, rounding of the posterior lid margin, sparse lashes, and absent meibomian gland orifices. So this is a variant of sebaceous gland carcinoma called the vegetoid variant, and that is very dangerous. And early manifestations of Zeiss gland vegetoid variant can look like this. This is very subtle, looks like inflammation, but you can see that the lashes are bushy here, there's sparse in the involved area, and meibomian gland orifices are missing. So this is definitely a early onset vegetoid sebaceous gland carcinoma. In benign tumors, of course, capillary hemangioma of infancy can be very safely treated with propranolol currently, but you should be aware of the systemic manifestations which I have listed here. This is capillary hemangioma, very easily treatable with propranolol 2 milligram per kg body weight given for 6 to 8 weeks is very effective. But when a patient does not respond in 6 weeks' time, that is a ground for referral because the patient may not have capillary hemangioma. It may be an arteriovenous malformation, you might have misdiagnosed it, or it is the non-responsive variant, which will need additional form of treatment, such as intralesional triamcinolone, to which it responds beautifully. Now, propranolol did not work much. Intralesional triamcinolone acetonide, 6 weeks later, lesion is gone. So your amblyopia treatment would become much rapid. Now it looks like infection. This patient has received antibiotics for several weeks with no response. Now, infection without any symptoms. This patient has absolutely no pain. She has a skin ulcer. So what looks like infection that does not respond to antibiotics and has necrotic patches on the skin and induration could be a T-cell lymphoma. So any presumed infection not respond to standard treatment again warrants referral. Now, this child came with bilateral eyelid swelling, which was thought to be allergic inflammatory, and this child was given steroids for several weeks. The moment we stopped steroids on a Friday evening, that's when he had come. By Monday morning, his condition has worsened. So this was definitely not inflammatory. This was an infiltrative lesion. Here was a case of leukemia. Now, if you have two similar cases, two eyelid swelling, patients with eyelid swelling, how to differentiate infiltrative versus inflammatory? Just look at the eyelid crease. Eyelid crease becomes prominent if it is infiltrative because infiltrative lesions are typically above the level of the tarsus. Eyelid crease remains normal or becomes prominent, whereas inflammatory does not have any boundary. It affects the pretarsal skin as well, and that causes obliteration of the lid crease. So that's one of the differentiating points. This is a patient of xanthogranuloma. Again, you see very prominent eyelid crease, and patients with xanthogranuloma, adult onset xanthogranuloma can have systemic connotations and they need referral. Now coming to just stop me whenever my time ends because yeah. This is a patient with conjunctival pigmentation. Go back and look at your grandparents or yourselves for that matter very carefully. You will have some pigmentation. Asian Indians are bound to have conjunctival pigmentation. As long as it is bilateral, symmetrical, has this cobblestone kind of an appearance, and fine pigmentation, even of peripheral cornea, nothing to worry about as long as it is symmetrical. But the moment there is asymmetry like this, that is something to worry about. This patient has some pigmentation even in the left eye, very subtle, but the right eye pigmentation is dramatic. Whenever there is asymmetry, you have to rule out primary acquired melanosis, which is a pre-malignant condition. If it is not cobblestone but peppery, away from the limbus, or if it is present in the fornix like this, you should rule out primary acquired melanosis, and you can see a fornicial PAM and a prompt melanoma. Primary acquired melanosis contributes to 75% of conjunctival melanoma, and you should be very aware of this condition. Now, these are four youngsters who have a pigmented conjunctival lesion. All of these are nevi. If you have any doubt at all, you can go through this mental checklist: interpalpebral location, variable pigmentation, right from tan brown to dark chocolate brown, no corneal epithelial invasion, stops right at the limbus, no episcleral fixity, absence of intrinsic vascularity, but a feeder vessel may still be present. All these are indicators of a nevus. Nevi also have microcysts. Nevi are like sponges, and microcysts and macrocysts can be picked up on anterior segment imaging. UBM and ASOCT are very useful. And when a nevus turns into a melanoma, that is a ground for referral. What happens when a nevus turns into melanoma? It acquires additional intrinsic vascularity. It acquires a lot of blood vessels from all layers, scleral, episcleral, conjunctival, all blood vessels come to feed this hungry tumor, and there is solidity of the lesion. It loses its cyst. So this was always a nevus, and from this has arisen a melanoma. Now this is a patient again who had a nevus always, and from there started a melanoma, and This is a clear-cut case of melanoma. So melanoma is supposed to be nodular, fleshy, with lot of blood supply, which is coming at all levels, and lot of intrinsic vascularity as well, and breaching the limbal barrier. So that's again a ground for referral. Now, if you have patients who have a perilimbal lesion, sometimes patients are operated as pterygium, and that turns out to be squamous cell carcinoma. Pterygium actually has desmoplastic activity. These blood vessels are dragged towards the lesion. If this is the apex of the pterygium, then all the blood vessels are coming towards it. Whereas in OSSN, ocular surface squamous neoplasia, that doesn't happen. Blood vessels are gently drawn towards the lesion. They're more prominent, and the lesion has keratin. So if a lesion were to have keratin, abnormal vascularity like this corkscrew appearance of blood vessels, keratin, abnormal vascularity, and staining with rose bengal are 97% sensitive and 98% specific to the diagnosis of OSSN. So if a conjunctival lesion may look like pterygium or pengicula but has abnormal vascularity, stains with rose bengal, and has specks of keratin, you should treat it like OSSN. If you have any doubt at all, you can do anterior segmentosity, where a grayish normal corneal epithelium transforms into hyperreflective hyperplastic epithelium and ends with an abrupt snout. That is diagnostic of OSSN. Now, in intraocular tumors, if you have a patient with unilateral shallow anterior chamber with a bump, irregular depth of anterior chamber, you must do imaging. Imaging is mandatory to know whether it is a cystic lesion, which is nothing but an innocuous cyst, or a solid lesion, which could be a melanoma or a melanocytoma. Just looking at this will not tell you whether it is a solid or a cystic lesion. So imaging is mandatory. And if you have a patient with unilateral glaucoma in young individual, then pupil is the key. Unilateral glaucoma with a lot of pigmentation, pupil nice, round and central, no NVI, no correctopia, ectropia, uvea, clear-cut melanocytoma. Whereas this patient was operated for trabeculectomy, where the pupil has correctopia and ectropia uvea, and behind the PI you see a black mass. This is a patient with melanoma. And when we enucleate it, you find that the scleral flap already contains tumor, and the bleb also has a tumor. So his intraocular tumor has been made extraocular by missing the diagnosis. Sentinel vessel is a serious business, because sentinel vessel can be an indicator of a ciliary body melanoma. Ciliary body melanomas are often hidden, and unless you look at the patient with extreme, deviation of the eye with the slit lamp angulated in extremely opposite direction, with pupil fully dilated, you may even miss this subtle elevation that is showing through. This is a patient with cataract with a sentinel blood vessel, and the cataract surgeon has promptly done a B scan to detect that ciliary body melanoma. So if there is a single sentinel vessel, you should be worried about it. The uveitis and hypopyon in an extreme age. This is an elderly individual with what looks like granulomatous uveitis. This is the imaging which shows thickened iris with nodules. This was a case of tapioca melanoma. This is a young individual with recent change in bowel habits with alternating constipation and diarrhea, with lot of iris nodules, looks like granulomatous uveitis, yellow hypopyon. This was adenocarcinoma of the colon metastasizing into the eye. Young elderly individual with a white hypopyon, absolutely white eye. So white-eyed hypopyon is diagnostic of either lymphoma or leukemia. This is again a patient with white-eyed hypopyon. So in an elderly individual, white-eyed hypopyon is diagnostic of lymphoma or leukemia, whereas in a child, it could be retinoblastoma, as you see here, or even medulloepithelioma, which has much larger balls of cells which look like pseudohypopyon. Now, vitreous haze can hide a lot. This is not a case of vitritis, because under the haze, you see yellowish placoid lesions in the retina, which is very obvious in this patient. Sub-RP and RP infiltrates. This is retinovitreal lymphoma. So any intraocular tumor is worth a referral. This is a patient with lymphoma. This is a patient with multifocal bilateral metastasis, creamy white lesions. In fact, this patient did not give a history of systemic condition at all. He came with loss of vision, and only on further evaluation was he found to have small cell carcinoma of the lung. Any patient with metamorphopsia, etc., may actually look like sometimes CSR, but you should always look for a subtle pink lesion, that is choroidal hemangioma, which will need treatment. A pigmented lesion with lot of drusen on top is generally a nevus, whereas this is a melanoma. And if you have something in between, doesn't look like a nevus, doesn't look like a melanoma yet, small 2 millimeter size lesion, this patient refused treatment and it has promptly grown in 6 months' time. So this was actually a melanoma. So if you have a diagnostic dilemma at all, look at thickness more than 2 millimeter, subretinal fluid, presence of symptoms such as loss of vision, presence of orange pigment or lipofuscin, margin very close to the optic disc and fovea, and following on ultrasound, halo because of RPE loss, and absence of drusen. These are all the signs that will indicate that this is actually a case of melanoma. Most intraocular tumors need a referral, and if a child were to come to you with leukocoria, never take it light. Leukocoria can be because of cataract, I agree, but if it is something behind the lens, that would need referral. Even if you think it is PHPV, etc., you should definitely refer these patients. Squint is a sign of retinoblastoma in a quarter of patients. If a child were to come to you with squint, never leave the child without complete dilatation and looking at the fundus. These are some of the simulating lesions looking like congenital glaucoma, phthisis bulbi, hyphema with even an evidence of lid injury. All these have retinoblastoma. So leukocoria and squint in children need evaluation. In proptosis, I would say every patient with proptosis need not be referred. This is a patient with exophthalmos. So you should learn to evaluate exophthalmos, thyroid exophthalmos based on scoring system. And if a patient has active disease, that would need treatment. Patients who have disease like this or diplopia or severe proptosis, exophthalmos with inflammation, these are active thyroid eye disease that need treatment. And any patient with proptosis with a tumor lying behind definitely would warrant a referral. So this is what I could cover in the short time. I know you gave me long enough time, but the spectrum is so large that I could only cover about 50-60% of the common ones. So if you remember some of these, then you can go back and remember who is good, who is bad, and who is ugly. Thank you so much.
Yeah, that was absolutely wonderful. As I mentioned, Rohan, a walking, talking encyclopedia and a textbook in his own right. I have every time keep learning from whatever he has presented, and look at the cases, the plethora of cases. This collection, you can't have that easily. It is a lifetime collection, lifetime achievement award. Fantastic. I mean, brilliant cases. And as I said, in one sitting, you can't go through what he has said. You need multiple sittings to go through what exactly he's trying to be saying and what exactly he meant. So the question, one of the question is, anything which is abnormal, and you rightly said that we cannot treat it on our own. It should be referred immediately. Absolutely. But how to break the news to relatives is one question that, an ophthalmologist is not used to. An oncosurgeon is used to that. But to break the heartbreaking news of a retinoblastoma to a parent is really heartbreaking to anybody. How would you like to do that? How should you be doing that?
But you should be very gentle because retinoblastoma is curable currently with more than 98% life salvage. Even in advanced situations, it can be cured, eye can be saved, and vision can be saved as well. So you give that good news that, well, your child has an eye cancer, but we can definitely save his life, eye, and vision. So you would need referral. And that is the starting point. Of course, when they meet an ocular oncologist, they'll be given further details about it, and the news will slowly sink in, but they should not go with a false sense of security that it is something innocuous, or they should not be so scared that they would refuse to go to you know oncologist or whatever.
Can I bring in Dr. Gaurav here, the chairman ARC of IRSI? Good evening, sir.
So, so I think you covered it up so well, and as I would understand, you would have, if we had given you an hour to speak, I think you would have still, kind of needed more time still to complete, something, and we would have all been spellbound for that whole hour. Anyway, I think for our young people, the message is very clear. What Dr. Santosh said, and what I could, the part that I could catch, that when to refer and when to kind of how to suspect and how to kind of follow up. I think more than me, I think we should have our younger people and the other faculty put in their thoughts and questions, because that they will definitely have better things to ask than me. So I'll pass it on to our younger people.
One question I had, sir, which was that, is there any primary investigation that should be done by a general ophthalmologist before referring the patient?
For eyelid lesions, well, investigations may not be required because some of these are very specialized. Like we might want to do a head and neck PET scan, things like that, depending on what lesion it is. For ocular surface lesions, anterior segment OCT is very useful. So if you have it, you can as well do it. But do all along the lesion, not at one point of the lesion. If you do a raster scan with the entire lesion scan, that will be very useful rather than doing a single point ACE OCT. For orbital tumors, I think if you have already diagnosed a tumor, that means that you've already done some form of imaging. It is not going to be much help to the patient if you have already done a CT scan to get an MRI scan also done before the patient consults a oculoplasty specialist or an oncologist, because they might have certain specifications in mind as to how they want the MRI scan done. For example, diffusion weighted images, etc. So whatever protocols they have, let them use that rather than getting it done and having to repeat it later.
Right.
Is there any time frame that someone should, refer a patient, or should, wait for a couple of months and then send it?
Couple of months is not ideal, within a few weeks, but a child with retinoblastoma of course would need referral the same week. If anybody is losing vision because of a tumor that is pressing on the optic nerve with compression optic neuropathy, or thyroid eye disease with compression optic neuropathy, they are emergencies. As long as vision is not at stake and the tumor has been growing very slowly, they can wait for a few weeks before they can reach an ocular oncologist or an oculoplasty surgeon.
What about the lesions on the lid margins and otherwise? Would you be doing like an FNAC? Should you be taking a small biopsy and send it for histopathology before sending it?
Well, if you are thinking of malignant lesion, it is ideal not to do a biopsy, because when we do excision of these eyelid lesions, we completely excise these, not do a small biopsy, unless a destructive surgery is required. If a lesion is very extensive and if you think that exentration may be the treatment of choice, for medical legal purposes, and to be sure to have that kind of a what do you call, the patient has to be conveyed the news that the patient will need a destructive surgery. To have that confidence, you might want to do an incisional biopsy. But if the diagnosis is obvious, then you never want to do an incisional biopsy and disturb the lesion. Dictum is that if a cat looks like a cat, it is a cat, right? So you don't want to kind of do a genetic testing on a cat to say it is a cat. So in ocular oncology, it's so interesting because everything is visible and is seen. This is the only field of medicine except dermatology where everything is seen, right? So it's very interesting, except orbital tumors, of course, which still are sometimes difficult to diagnose.
If I may bring in Dr. Akshay once, sir, one question is that if there is misdiagnosis, like if a patient comes to you and he has been misdiagnosed earlier, then what is the way to counsel that patient? Like, it's not just that patient comes to you at a tertiary center. Sometimes a lot of misdiagnosed patients come to us at secondary centers as well. So how do you go about counseling these patients?
Well, we just tell them that your doctor has done his best, and now that you have come here and our additional tests show that this is slightly different, and then we take it from there. Never ever say anything bad or wrong about the primary doctor. He would not have misdiagnosed it because of his intention to misdiagnose it. He probably has misdiagnosed it because he has not seen such a lesion. And it is possible in early practice for many youngsters not to have seen these lesions, especially if you are done residency in a medical college. Sometimes they may not have subspecialties evolved so much. Or if you have done a fellowship in, say, for example, in cataract refractive surgery, you may not have had an occasion to, even in, say, institutes, you may not have had an occasion to see oculoplasty and oncology spectrum. So it's always possible that you may not have seen it. So it is okay to misdiagnose it and learn.
Frank admission, Rohan, I wouldn't have seen 10 to 15% in my lifetime also of what he has shown. And that is a genuine admission of what I'm saying. What do you say, Gaurav?
Completely agree, because when you get into, I think when I was doing my MS in MAMC, I would have seen a lot of things which I did not recognize, because as a resident you will not kind of, unless somebody is giving you structured teaching, and you have a consultant available every time to be able to consult each time, so you'll miss so many things. So I learned them the hard way. But subsequently, once you get into practice, and nowadays very few people actually do general ophthalmology practice, they would mostly try to specialize either into something or the other. And if you get into that, and you have other consultants in other specialities, you will end up not seeing many things which you would see in a general practice. So I really miss that part, because now I'm mostly doing cataract refractive. Nothing else comes to me. Either they'll go to the pediatric ophthalmologist, or to my cornea consultant, or to my retina or the uvea people. So I'll rarely see ocular tumors. But I completely agree with you on that.
One
But for example,
good way to learn is to send pictures to somebody who knows about this. Many residents and even fellows of different specialties send me, or general ophthalmologists, keep sending pictures on WhatsApp. These days, everything is accessible to smartphone for photography, and you send a picture, and if the person to whom you sent the picture opines that it is a tumor and gives the diagnosis, then if it is possible for you to manage locally, you can with the protocol. But if you can't, then you can always refer it.
I agree, Dr. Santosh. In fact, today, you have access to even the regular phones, and through the slit lamp, it's not difficult. I see my daughter Anshika, keep capturing images on the iPhone and sending her. And you have to have an inquisitive mind. So what's more important is that when you see something unusual, you should not just pass it on that this may be another thing that I don't know. you should always have that desire to know what it is, and maybe try to kind of. And we have so many groups now, we have so many ways of finding out from. You can always, I do that all the time, even though I'm doing refractive surgery for 20 years. Even today, when I see an unusual topography map, or I see an OCT epithelium thickness map which is unusual, and I want to consult 3 4 of my colleagues, I'll just send it out and ask that, do you think, and I do it every day in spite of being doing this for so many years. So I think we are learning every day from each other, and that's, you have to have that bent of thought that you're inquisitive enough to do this, I think.
Want to take a hint, and he's open if people send him photographs to give a diagnosis.
Yes.
That's a strong hint that he has given. Very sweet of him to say that.
Not just general ophthalmologists and other specialists, even his old fellows, we also send him photographs when we have cases that
They
we are
send the
having
photograph
difficulty.
just to brag about his management.
No, I think just to add to that, this is a line that I use very often. Sometimes patients try to put you in a spot, especially when there has been a diagnosis, and this is something that I learned from Dr. Santosh. He always keeps, he's has a poker face and very very calm, coolly explains. But if prodded and pushed, there's a line that he used, which I now often use. He says, "Your doctor has done the best. I am here to give my opinion on your condition, not an opinion on someone else's opinion." And I think that is very clear, because then the patients just stop asking, which is what we need to do, and not badmouth the referring doctor.
Excuse me, sir. I wanted to ask something that, sir, as PGs, we encounter so many cases of proptosis and squint. And so most of them are referred without any further evaluation. So what are some warning signs that can tell us that this is not benign and that this is something that requires urgent attention? Because a lot of these patients, we see that they just keep doing the rounds and they never get diagnosed. And then eventually they get tired and they leave. So what are some warning signs to look for in these patients?
Well, in a child with squint, the squint is mainly caused by visual deprivation in a patient with retinoblastoma, and that is because of a macular tumor, juxtapapillary tumor with subretinal fluid. So even if you can just look at the posterior pole without anesthesia, if that is clear, then definitely it is not because of retinoblastoma. Right? Peripheral retinoblastoma will not cause squint. So then you're clear. But ideally, you should do a full fundus evaluation with indentation to rule out retinoblastoma. But if you have seen the posterior pole, absolutely you're clear that it is not because of retinoblastoma. It could be because of something else. No other causes for squint. In proptosis, anything that is rapidly evolving is something that you should be worried about. If currently, whenever a patient comes to me, ask them to show all the pictures, open their mobile and show all the pictures that they can show, without hesitation. All right. So if they show a series of pictures and if something was there 10 years ago and very slowly has increased, then you're quite sure that it is a benign lesion. Whereas something that has evolved in 6 months or 9 months and the patient has ocular motility restriction, the patient has diplopia, or patient has anisocoria, patient has disc edema, etc. It's either inflammation or a tumor. Extremes of age group you should be worried about. A child with proptosis and somebody beyond 50, 60 years of age with proptosis are the ones which fall into the category of tumors, whereas everybody in the middle either have inflammation or infection. So those are dictums, but then you can't apply that to every patient. You have to individualize.